Lewis's Medical Surgical Nursing, 11th edition, Chapter 16, Fluid, Electrolyte, and Acid-Base Imbalances. Homeostasis. Body fluids and electrolytes play an important role in maintaining homeostasis, the body's stable internal environment. Body fluids are in constant motion transporting nutrients, electrolytes, and oxygen to cells and carrying waste products away from cells. The body uses many adaptive responses to keep the composition and volume of fluids and electrolytes within narrow limits to maintain homeostasis and promote health. Many diseases and their treatments affect fluid and electrolyte balance. Conceptually, these imbalances are often reflected by changes in perfusion, gas exchange, mobility, and cognition. For example, a patient with metastatic colon cancer may develop hyperkalemia because of bone destruction from tumor invasion and have severe muscle weakness and confusion. Chemotherapy used to treat the cancer may result in nausea and vomiting, which causes dehydration and acid-base imbalances. When correcting dehydration with IV fluids, the patient needs close monitoring to prevent fluid overload. It is important to anticipate the potential for fluid and electrolyte imbalances associated with certain disorders and medical therapies, recognize the signs and symptoms of imbalances, and intervene with appropriate action. This chapter describes the 1. Normal control of fluids, electrolytes, and acid-base balance, 2. Conditions that disrupt homeostasis and resulting manifestations, and 3. Actions that the healthcare provider and you can take to manage fluid, electrolyte, and acid-base imbalances and restore homeostasis. Water content of the body. The body is composed primarily of water. It accounts for about 50 to 60% of body weight in the adult. Water content varies with body mass, gender, and age, figure 16.1. Lean body mass has a higher percentage of water, while adipose tissue has a lesser percentage of water. So the more fat present in the body, the less the total water content. Women generally have a lower percentage of body water because they tend to have less lean body mass than men. Older adults also tend to have less lean body mass, resulting in a lower percentage of body water when compared to younger adults. In older adults, body water content averages 45 to 50% of body weight. This places them at higher risk for fluid-related problems than young adults. Body fluid compartments. The two fluid compartments in the body are the intracellular space, inside the cells, and extracellular space, outside the cells, figure 16.2. About 2/3 of body water is found within cells and is termed intracellular fluid, ICF. ICF makes up about 40% of body weight of an adult. This means a 70-kilogram young man would have about 42 liters of water, with about 28 liters of that water within his cells. The fluid in the extracellular space is extracellular fluid, ECF. The two main compartments containing ECF are the interstitial fluid, the fluid in the spaces between cells, and the intravascular fluid or plasma, the liquid part of the blood. Other ECF compartments include lymph and transcellular fluids. Transcellular fluids include cerebrospinal fluid, fluid in the GI tract and joint spaces, and pleural, peritoneal, intraocular, and pericardial fluid. ECF makes up about 1/3 of the body water. This amounts to about 14 liters in a 70-kilogram man. About 1/3 of ECF is in the intravascular space as plasma, 3 liters in a 70-kilogram man, and 2/3 is in the interstitial space, 10 liters in a 70-kilogram man. The fluid in the transcellular spaces totals about 1 liter at any given time. Calculation of fluid gain or loss. 1 liter of water weighs 2.2 pounds, 1 kilogram. Body weight change, especially sudden change, is an excellent indicator of overall fluid volume loss or gain. For example, if a patient drinks 240 milliliters, 8 ounces, of fluid, weight gain will be 0.5 pounds or 0.23 kilograms. A patient receiving diuretic therapy who loses 4.4 pounds or 2 kilograms in 24 hours has a fluid loss of about 2 liters. An adult patient who is fasting may lose 1 to 2 pounds per day. A weight loss exceeding this is likely due to loss of body fluid. Electrolytes. Electrolytes are substances whose molecules dissociate or split into ions when placed in water. Ions are electrically charged particles. Cations are positively charged ions. Examples include sodium, Na+, potassium, K+, calcium, Ca2+, and magnesium, Mg2+, ions. Anions are negatively charged ions. Examples include bicarbonate, HCO3-, chloride, Cl-, and phosphate, PO4-3- ions. Most proteins bear a negative charge and thus are anions. Measurement of electrolytes. The concentration of electrolytes in body fluids is expressed in milliequivalents, MEQ, per liter. Since electrolytes are active chemicals, it is useful to express their concentration according to their chemical activity, or the number of electrolytes able to combine chemically. Ions combine milliequivalent for milliequivalent. For example, 1 MEQ, 1 mmol of sodium combines with 1 MEQ, 1 mmol of chloride. Electrolyte composition of fluid compartments. Electrolyte composition varies between ECF and ICF. The overall concentration of electrolytes is nearly the same in the ECF and ICF. However, concentrations of specific ions differ greatly. Figure 16.3. In ECF, the main cation is sodium, with small amounts of potassium, calcium, and magnesium. The primary ECF anion is chloride, with small amounts of bicarbonate, sulfate, and phosphate anions. In ICF, the prevalent cation is potassium, with small amounts of magnesium and sodium. The prevalent ICF anion is phosphate, with some protein and a small amount of bicarbonate. Table 16.1 lists normal serum electrolyte values. Mechanisms controlling fluid and electrolyte movement. The movement of electrolytes and water between ICF and ECF to maintain homeostasis involves many different processes, including simple diffusion, facilitated diffusion, and active transport. Water moves as driven by two forces, hydrostatic pressure and osmotic pressure. Diffusion. Diffusion is the movement of molecules from an area of high concentration to low concentration. Figure 16.4. Net movement of molecules stops when the concentrations are equal in both areas. It occurs in liquids, gases, and solids. Simple diffusion requires no external energy. Facilitated diffusion. Facilitated diffusion involves the use of a protein carrier in the cell membrane. The protein carrier combines with a molecule, especially one too large to pass easily through the cell membrane, and helps move the molecule across the membrane from an area of high to low concentration. Like simple diffusion, facilitated diffusion is passive and requires no energy. An example of facilitated diffusion is glucose transport into the cell. The large glucose molecule must combine with a carrier molecule to be able to cross the cell membrane and enter most cells. Active transport. Active transport is a process in which molecules move against the concentration gradient. External energy is needed for this process. An example is the sodium-potassium pump. The concentrations of sodium and potassium differ greatly intracellularly and extracellularly. Figure 16.3. To maintain this concentration difference, the cell uses active transport to move sodium out of the cell and potassium into the cell. Figure 16.5. The energy source for this movement is adenosine triphosphate, ATP, which is made in the cell mitochondria. Osmosis. Osmosis is the movement of water down a concentration gradient, that is, from a region of low solute concentration to one of high solute concentration across a semi-permeable membrane. Osmosis requires no outside energy sources. It stops when the concentration differences disappear, or when hydrostatic pressure builds and opposes any further movement of water. Imagine a chamber with two compartments separated by a semi-permeable membrane, one that allows only the movement of water, figure 16.6. If you add albumin to one side, water will move from the less concentrated side, which has more water, to the more concentrated side of the chamber, which has less water, until the concentrations are equal. Whenever dissolved substances are contained in a space with a semi-permeable membrane, they can pull water into the space by osmosis. The concentration of the solution determines the strength of the osmotic pull. The higher the concentration, the greater a solution's pull, or osmotic pressure. Osmotic pressure is measured in milliosmoles, MOSM. It may be expressed as either fluid osmolarity or fluid osmolality. Although you will often see the terms osmolarity and osmolality used interchangeably, they are different measurements. Osmolarity measures the total milliosmoles per liter of solution, or the concentration of molecules per volume of solution, MOSM per liter. Osmolality measures the number of milliosmoles per kilogram of water, or the concentration of molecules per weight of water. Osmolality is the preferred measure to evaluate the concentration of plasma, urine, and other body fluids, as changes in the ECF osmolality can significantly influence changes in the ICF osmolality. These changes can affect normal cell function. Measurement of osmolality. Osmolality is nearly the same in the various body fluid spaces. Therefore, measuring or estimating plasma osmolality is a useful way to assess the state of the body's water balance. Calculate the plasma osmolality using the following formula. Plasma osmolality equals 2 times sodium plus Bun divided by 2.8 plus glucose divided by 18. Normal plasma osmolality is between 280 and 295 milliosmoles per kilogram. A value greater than 295 milliosmoles per kilogram indicates that the concentration of solute is too great, or the water content is too little. This condition is termed water deficit. A value less than 275 milliosmoles per kilogram indicates too little solute for the amount of water, or too much water for the amount of solute. This condition is termed water excess. Both conditions are clinically significant. Urine osmolality can range from 100 to 1300 milliosmoles per kilogram. It depends on fluid intake, the amount of antidiuretic hormone, ADH, in circulation, and the renal response to ADH. Osmotic movement of fluids. The osmolality of the fluids surrounding cells affects them. Fluids with the same osmolality as the cell interior are isotonic. Normally, ECF and ICF are isotonic to one another, so no net movement of water occurs. Changes in the osmolality of ECF change the volume of cells. Solutions in which the solutes are less concentrated than in the cells are hypotonic, hypoosmolar. If a cell is surrounded by hypotonic fluid, water moves into the cell, causing it to swell and possibly burst. Fluids with solutes more concentrated than in cells, or an increased osmolality, are hypertonic, hyperosmolar. If hypertonic fluid surrounds a cell, water leaves the cell to dilute ECF. The cell shrinks and may eventually die. Figure 16.7. Hydrostatic pressure. Hydrostatic pressure is the force of fluid in a compartment pushing against a cell membrane or vessel wall. In the blood vessels, hydrostatic pressure is the BP generated by the heart's contraction. Hydrostatic pressure in the vascular system gradually decreases as the blood moves through the arteries until it is about 30 milligrams of mercury in the capillary bed. At the capillary level, hydrostatic pressure is the major force that pushes water out of the vascular system and into the interstitial space. Oncotic pressure. Oncotic pressure, colloidal osmotic pressure, is the osmotic pressure caused by plasma colloids, large molecules, in solution. The major colloids in the vascular system contributing to osmotic pressure are proteins such as albumin. Plasma has large amounts of protein, while the interstitial space has very little. Plasma protein molecules attract water, pulling fluid from the tissue space to the vascular space. Under normal conditions, plasma oncotic pressure is about 25 millimeters of mercury. The small amount of protein found in the interstitial space exerts an oncotic pressure of about 1 millimeter of mercury. Fluid movement in capillaries. As plasma flows through the capillary bed, four factors determine if fluid moves out of the capillary and into the interstitial space, or if fluid moves back into the capillary from the interstitial space. The amount and direction of movement are determined by the interaction of 1. Capillary hydrostatic pressure, 2. Plasma oncotic pressure, 3. Interstitial hydrostatic pressure, and 4. Interstitial oncotic pressure. Capillary hydrostatic pressure and interstitial oncotic pressure move water out of the capillaries. Plasma oncotic pressure and interstitial hydrostatic pressure move fluid into the capillaries. At the arterial end of the capillary, capillary hydrostatic pressure exceeds plasma oncotic pressure, and fluid moves into the interstitial space. At the venous end of the capillary hydrostatic pressure is lower than plasma oncotic pressure, drawing fluid back into the capillary by the oncotic pressure created by plasma proteins. Figure 16.8. Fluid shifts. If capillary or interstitial pressure change, fluid may abnormally shift from one compartment to another, resulting in edema or dehydration. Shifts of plasma to interstitial fluid. Edema, an accumulation of fluid in the interstitial space, occurs if venous hydrostatic pressure rises, plasma oncotic pressure decreases, or interstitial oncotic pressure rises. Edema may also develop if an obstruction of lymphatic outflow causes a decrease in the removal of interstitial fluid. Elevation of venous hydrostatic pressure. Increasing the pressure at the venous end of the capillary inhibits fluid movement back into the capillary, which results in edema. Causes of increased venous pressure include fluid overload, heart failure, liver failure, obstruction of venous return to the heart, e.g. tourniquets, restrictive clothing, venous thrombosis, and venous insufficiency, e.g. varicose veins. Decrease in plasma oncotic pressure. Fluid stays in the interstitial space if the plasma oncotic pressure is too low to draw fluid back into the capillary. Low plasma protein content decreases oncotic pressure. This can result from excess protein loss, renal disorders, deficient protein synthesis, liver disease, and deficient protein intake, malnutrition. Elevation of interstitial oncotic pressure. Trauma, burns, and inflammation can damage capillary walls and allow plasma proteins to accumulate in the interstitial space. This increases interstitial oncotic pressure, draws fluid into the interstitial space, and holds it there. Shifts of interstitial fluid to plasma. An increase in the plasma osmotic or oncotic pressure draws fluid into the plasma from the interstitial space. This could happen when we give colloids, dextran, mannitol, or hypertonic solutions. Increasing the tissue hydrostatic pressure is another way of causing a shift of fluid into plasma. Wearing elastic compression gradient stockings or hose to decrease peripheral edema is a therapeutic application of this effect. Fluid spacing. Fluid spacing is a term used to describe the distribution of body water. First spacing describes the normal distribution of fluid in ICF and ECF compartments. Second spacing refers to an abnormal accumulation of interstitial fluid, i.e. edema. Third spacing occurs when excess fluid collects in the non-functional area between cells. This fluid is trapped where it is difficult or impossible for it to move back into the cells or blood vessels. Third spacing occurs with ascites, fluid leaking into the abdominal cavity with peritonitis or pancreatitis, and edema associated with burns, trauma, or sepsis. Regulation of water balance. Many factors are involved in maintaining the finely tuned balance among water intake, use, and excretion. For proper fluid balance, an average healthy adult needs a daily water intake between 2,000 and 3,000 milliliters. Table 16.2. This amount replaces what the body loses in urinary output and insensible losses. Oral fluid intake accounts for most of the water intake. Water intake also includes water from food metabolism and water present in solid food. Insensible water loss, which is invisible vaporization from the lungs and skin, helps regulate body temperature. Accelerated body metabolism, which occurs with increased body temperature and exercise, increases the amount of water lost and may result in the need for additional water replacement. Do not confuse water loss through the skin with the vaporization of water excreted by sweat glands. Insensible perspiration causes only water loss. Excess sweating, sensible perspiration, caused by exercise, fever, or high environmental temperatures may lead to large losses of water and electrolytes. Hypothalamic pituitary regulation. Water ingestion equals water loss in the person who has free access to water, intact thirst, an ADH mechanism, and normally functioning kidneys. A body fluid deficit or increase in plasma osmolality activates osmoreceptors in the hypothalamus. This stimulates thirst and the release of ADH from the posterior pituitary gland. ADH acts on the distal tubules and collecting ducts in the kidneys by making them more permeable to water. The result is increased water reabsorption from the tubular filtrate in the blood and decreased excretion in the urine. Because ADH is only able to regulate how much water the body holds onto, an intact thirst mechanism is our main protection against developing dehydration or hyperosmolality. Thirst causes us to increase the amount of water we drink. Together, these result in increased free water in the body, decreasing plasma osmolality and restoring fluid volume. Many factors influence ADH secretion and thirst. Decreased BP, nausea, pain, hypoglycemia, and hypoxemia stimulate ADH release. In the post-operative patient, the stress response to surgery and receiving analgesics and anesthesia cause ADH release and decreased osmolality. The unconscious or cognitively impaired patient is at increased risk for fluid deficit and hyperosmolality because of an inability to express thirst and act on it. A dry mouth will cause a person to drink, even when there is no body water deficit. Renal regulation. The primary function of the kidneys is to regulate fluid and electrolyte balance by adjusting urine volume and the excretion of most electrolytes. See Chapter 44. The kidneys filter the total plasma volume many times each day. In the average adult, the kidneys reabsorb 99% of this filtrate, producing around 1.5 liters of urine per day. Under the influence of ADH, aldosterone, and other hormones, selective reabsorption and secretion of water and electrolytes in the renal tubules result in urine that is different in composition and concentration from plasma. This process helps maintain normal plasma osmolality, electrolyte balance, blood volume, and acid-base balance. With severely impaired renal function, the kidneys cannot maintain fluid and electrolyte balance. This condition results in edema, potassium, and phosphate retention, acidosis, and other electrolyte imbalances. See Chapter 46. Adrenal cortical regulation. Glucocorticoids and mineralocorticoids secreted by the adrenal cortex help regulate water and electrolyte balance. The glucocorticoids, e.g. cortisol, primarily have an anti-inflammatory effect and increase serum glucose levels. The mineralocorticoids, e.g. aldosterone, enhance sodium retention and potassium excretion. Figure 16.9. When sodium is reabsorbed, water follows because of osmotic changes. Aldosterone is a mineralocorticoid with strong sodium retaining and potassium excreting capabilities. Decreased renal perfusion or decreased sodium in the distal part of the renal tubule activates the renin-angiotensin-aldosterone system, ROS, resulting in aldosterone secretion. In addition to the ROS, increased serum potassium, decreased serum sodium, and adrenocorticotropic hormone, ACTH, stimulate aldosterone secretion. Aldosterone increases sodium and water reabsorption in the renal distal tubules, decreasing plasma osmolality and restoring fluid volume. Cortisol is the most abundant glucocorticoid. In large doses, cortisol has both glucocorticoid, glucose elevating and anti-inflammatory, and mineralocorticoid, sodium retention, effects. Normally, cortisol secretion is in a diurnal or circadian pattern. Increased cortisol secretion occurs in response to physical and physiologic stress. This affects many body functions, including fluid and electrolyte balance. Figure 16.10. Cardiac regulation. Natriuretic peptides, including atrial natriuretic peptide, ANP, and B-type natriuretic peptide, BNP, are hormones made by cardiomyocytes. They are made in response to increased atrial pressure, increased volume, such as occurs in heart failure, and high serum sodium levels. They are natural antagonists to the ROS and suppress secretion of aldosterone, renin, and ADH, and the action of angiotensin II. In the renal tubules, peptides promote excretion of sodium in water, decreasing blood volume and BP. Gastrointestinal regulation. In addition to oral intake, the GI tract normally secretes around 8,000 milliliters of digestive fluids each day. The GI tract normally reabsorbs most of this fluid, with only a small amount eliminated in feces. This is why diarrhea and vomiting, which prevent GI reabsorption of secreted fluid, can lead to significant fluid and electrolyte loss. Gerontologic considerations, fluid and electrolytes. The older adult has normal physiologic changes that increase susceptibility to fluid and electrolyte imbalances. Structural changes to the kidneys and a decrease in the renal blood flow lead to decreased glomerular filtration rate and loss of the ability to concentrate urine and conserve water. Hormonal changes include a decrease in renin and aldosterone and an increase in ADH and ANP. Subcutaneous tissue loss and thinning of the dermis lead to increased moisture loss through the skin and an inability to respond quickly to heat or cold. Do not automatically attribute older patients' fluid and electrolyte problems to the natural processes of aging. Throughout this chapter are suggestions for adapting your assessment and nursing interventions when caring for the older adult. Fluid volume imbalances. Fluid and electrolyte imbalances occur in most patients with a major illness or injury because illness disrupts normal homeostatic mechanisms. Illness or disease directly causes some fluid and electrolyte imbalances, e.g., burns, heart failure. Other times, therapeutic measures, e.g., colonoscopy preparation or diuretics, cause or contribute to imbalances. Perioperative patients are at risk for developing fluid and electrolyte imbalances because of fluid restrictions, blood or fluid loss, and the stress of surgery. Fluid and electrolyte imbalances are commonly classified as deficits or excesses. ECF volume deficit, hypovolemia, and ECF volume excess, hypervolemia, are common clinical conditions. ECF volume imbalances are usually accompanied by one or more electrolyte imbalances, particularly changes in the serum sodium level. Although each imbalance is discussed separately in this chapter, it is common for more than one imbalance to occur in the same patient. For example, a patient with prolonged nasogastric suction will lose sodium, potassium, hydrogen, and chloride ions. This may result in sodium and potassium deficiencies, a fluid volume deficit, and metabolic alkalosis caused by the loss of hydrochloric acid. Fluid volume deficit. Fluid volume deficit can occur with abnormal loss of body fluids, e.g. diarrhea, vomiting, hemorrhage, and polyuria, inadequate fluid intake, or a shift from plasma to interstitial fluid. Though often used interchangeably, fluid volume deficit and dehydration are not the same. Dehydration refers to loss of pure water alone without a corresponding loss of sodium. Table 16.3 lists causes and manifestations of fluid volume deficit. Intraprofessional care. Managing fluid volume deficit involves correcting the underlying cause and replacing both water and any needed electrolytes. Replacement therapy depends on the severity and type of volume loss. In mild losses, we can use oral rehydration. If the deficit is more severe, we replace volume with blood products or balanced IV solutions, such as isotonic 0.9 sodium chloride or lactated Ringer solution. The choice of fluid depends on the cause of patient's electrolyte status. For rapid volume replacement, 0.9% sodium chloride is preferred. Blood is given when volume loss is due to blood loss. Fluid volume excess. Fluid volume excess may result from excess intake of fluids, abnormal retention of fluids, e.g. heart failure, renal failure, or a shift of fluid from interstitial fluid into plasma fluid. Weight gain is the most consistent manifestation of fluid volume excess. Table 16.3 lists causes and manifestations of fluid volume excess. Interprofessional care. Managing fluid volume excess involves treating the underlying cause and removing fluid without producing abnormal changes in the electrolyte composition or osmolality of ECF. Diuretics and fluid restriction are the primary forms of therapy. Some patients also need sodium restrictions. If the fluid excess leads to ascites or pleural effusion, an abdominal paracentesis or a thoracentesis may be needed. Nursing management, fluid volume imbalances. Nursing diagnoses and collaborative problems for the patient with a fluid imbalance include ECF volume deficit, fluid imbalance, impaired cardiac output, acute confusion, potential complication, hypovolemic shock, and ECF volume excess, fluid imbalance, impaired gas exchange, impaired tissue integrity, activity intolerance, disturbed body image, potential complications, pulmonary edema, and ascites. Nursing implementation. Daily weights. Daily weights are the most accurate measure of volume status. An increase of 1 kilogram, 2.2 pounds, is equal to 1,000 milliliters, 1 liter of fluid retention. Provided the person has maintained usual dietary intake or has not been on NPO status. Obtain the weight under standardized conditions. Weigh the patient at the same time every day, wearing the same clothes and on the same carefully calibrated scale. Remove excess bedding and empty all drainage bags before the weighing. If items are present that are not there every day, such as bulky dressings or tubes, note this along with the weight. Intake and output. Intake and output records give valuable information about fluid and electrolyte problems. An accurately recorded intake and output will identify sources of excess intake or fluid losses. Intake should include oral and IV fluids, tube feedings, and retained irrigation solutions. Output includes urine, excess perspiration, wound or tube drainage, vomitus, and diarrhea. Estimate fluid loss from wounds and perspiration. Note the amount and color of the urine and measure the urine specific gravity. Readings greater than 1.025 mean urine is concentrated, while readings less than 1.010 mean urine is dilute. Laboratory findings. Monitor laboratory results when available and calculate the serum osmolality. The patient with a fluid volume deficit often has increased blood urea nitrogen, or BUN, sodium, and hematocrit levels, with increased plasma and urine osmolality. With fluid volume excess, the patient will have decreased BUN, sodium, and hematocrit levels with decreased plasma and urine osmolality. Cardiovascular care. Monitor vital signs and perform a thorough cardiovascular assessment as needed. Changes in BP, central venous pressure, pulse force, and jugular venous distension reflect ECF volume imbalances. In fluid volume excess, the pulse is full, bounding, and not easily obliterated. Increased volume causes distended neck veins, jugular venous distension, increased central venous pressure, and high BP. Auscultate heart sounds, being alert for the presence of an S3. In mild to moderate fluid volume deficit, sympathetic nervous system compensation increases the heart rate and results in peripheral vasoconstriction to try to keep the BP within normal limits. Pulses may be weak and thready. Assess for orthostatic changes. Change in position from lying to sitting or standing may decrease BP or further increase the heart rate, orthostatic hypotension. In more severe deficits, hypotension may be present. Respiratory care. Monitor pulse oximetry and auscultate lung sounds as needed. ECF excess can cause pulmonary congestion and pulmonary edema, as increased hydrostatic pressure in the pulmonary vessels forces fluid into the alveoli. The patient will have shortness of breath and moist crackles on auscultation. The patient with ECF deficit will have an increased respiratory rate because of decreased tissue perfusion and resultant hypoxia. Give O2 as ordered. Patient safety. The patient with fluid volume deficit is at risk for falls because of orthostatic hypotension, muscle weakness, and changes in level of consciousness. Assess level of consciousness, gait, and muscle strength. Implement fall precautions. If orthostatic hypotension is present, teach the patient to change positions slowly when rising from a bed or chair. Place alarm monitors on patients who are confused and try to get out of bed without help. Skin care. Assess the skin for turgor and mobility. Normally, a fold of skin, when pinched, will readily move and, on release, rapidly return to its former position. In ECF volume deficit, there is diminished skin turgor with tenting, or a lag in the pinched skin fold's return to its original state. Skin areas over the sternum, abdomen, and anterior forearm are the usual sites we use to assess turgor. Figure 16.11. In older people, decreased skin turgor is less predictive of fluid deficit because of the loss of tissue elasticity. In mild fluid deficits, the skin may appear warm, dry, and wrinkled. These signs may be hard to assess in the older adult because the person's skin may be normally dry, wrinkled, and non-elastic. In more severe deficits, skin may be cool and moist if there is vasoconstriction to compensate for the decreased fluid volume. Oral mucous membranes will be dry, the tongue may be furrowed, and the person often is thirsty. Routine oral care is critical for the comfort of a patient who is dehydrated or on a fluid restriction. Edematous skin may feel cool because of fluid accumulation and a decrease in blood flow secondary to the pressure of the fluid. The fluid can stretch the skin, causing it to feel taut and hard. Assess edema by pressing with a thumb or forefinger over the edematous area. Use a grading scale to standardize the description. If an indentation ranging from 1+, slight edema, 2 mm indentation, to 4+, pitting edema, 8 mm indentation, remains when pressure is released. Assess for edema in areas where soft tissue overlie a bone, particularly the tibia, fibula, and sacrum. Good skin care is important. Protect tissues from extremes of heat and cold, prolonged pressure, and trauma. Frequent skin care and changes in position will prevent skin breakdown. Elevate edematous extremities to promote venous return and fluid reabsorption. Dehydrated skin needs frequent care without the use of soap. Applying moisturizing creams or oils increases moisture retention and stimulates circulation. Fluid therapy. Give IV fluids as ordered. Carefully monitor the rates of infusion of IV fluid solutions, especially when you are giving large volumes of fluid. This is especially true in patients with heart, renal, or neurologic problems. In the presence of fluid volume deficit, you can use several interventions to maintain adequate oral intake. Assess the patient's ability to obtain adequate fluids independently, express thirst, and swallow effectively. Fluids should be easily accessible. Provide a variety of fluids that the patient likes. Serve fluids at a temperature preferred by the patient. Offer fluids every 1 to 2 hours and at select times, such as when giving medications. Remind the patient to finish all drinks. If the patient is choosing to limit intake to decrease nocturia or incontinence, make it easier for the patient to reach the toilet when needed. Help those with physical limitations, such as arthritis, to open and hold containers. Involve the dietitian, speech therapist, or occupational therapist for help with patients with dysphagia or physical limitations. Sodium imbalances. Sodium, the main cation of ECF, plays a major role in maintaining the concentration and volume of ECF and influencing water distribution between ECF and ICF. Sodium is important in generating and transmitting nerve impulses, muscle contractility, and regulating acid-base balance. The serum sodium level reflects the ratio of sodium to water, not necessarily the amount of sodium in the body. Changes in the serum sodium level can reflect a primary water imbalance, primary sodium imbalance, or combination of the two. Sodium imbalances are typically associated with imbalances in ECF volume, figure 16.12 and 16.13. Because sodium is the primary determinant of ECF osmolality, sodium imbalances are typically associated with parallel changes in osmolality. The GI tract absorbs sodium from foods. Typically, daily intake of sodium far exceeds the body's daily requirements. Sodium leaves the body through urine, sweat, and feces. The kidneys primarily regulate sodium balance. The kidneys control ECF sodium concentrations by excreting or retaining water under the influence of ADH. Aldosterone plays a smaller role in sodium regulation by promoting sodium reabsorption from the renal tubules. Hypernatremia. Hypernatremia, high serum sodium, may occur with inadequate water intake, excess water loss, or rarely sodium gain. Because sodium is the major determinant of ECF osmolality, hypernatremia causes hyperosmolality. ECF hyperosmolality causes water to move out of the cells to restore equilibrium, leading to cellular dehydration. As discussed earlier, the primary protection against the development of hyperosmolality is thirst. Hypernatremia is not a problem in an alert person who has access to water, can sense thirst, and is able to swallow. Hypernatremia from water deficiency is often the result of an impaired level of consciousness or inability to obtain fluids. Several clinical states can produce hypernatremia from water loss, table 16.4. A deficiency in the synthesis or release of ADH from the posterior pituitary gland, central diabetes insipidus, or a decrease in kidney responsiveness to ADH, nephrogenic diabetes insipidus, can result in profound diuresis, producing a water deficit and hypernatremia. Hyperosmolality with osmotic diuresis can result from hyperglycemia associated with uncontrolled diabetes or giving concentrated hyperosmolar tube feedings. Excess sodium intake with inadequate water intake can also lead to hypernatremia. Examples of sodium gain include IV administration of hypertonic saline or sodium bicarbonate, use of sodium-containing drugs, excess oral intake of sodium, e.g. ingesting seawater, and primary aldosteronism, excess aldosterone secretion, caused by a tumor of the adrenal glands. Clinical manifestations. The manifestations of hypernatremia are primarily the result of water shifting out of cells into ECF with resultant dehydration and shrinkage of cells. Table 16.4. Dehydration of brain cells results in changes in mental status, ranging from drowsiness, restlessness, confusion, and lethargy to seizures and coma. If there is an accompanying ECF volume deficit, manifestations such as postural hypotension, tachycardia, and weakness occur. Nursing and interprofessional management, hypernatremia. Nursing diagnoses and collaborative problems for the patient with hypernatremia include electrolyte imbalance, fluid imbalance, risk for injury, potential complications, seizures, and coma. Nursing implementation. Managing hypernatremia depends on the underlying cause and the patient's volume status. In primary water deficit, fluid replacement is given either orally or IV with isotonic solutions, such as 0.9 sodium chloride. If the problem is sodium excess, expect diluting the high sodium concentration with sodium-free IV fluids, such as 5% dextrose in water, and promoting sodium excretion with diuretics. Dietary sodium intake is often restricted. If the patient has an altered sensorium or is having seizures, initiate seizure precautions. Monitor serum sodium levels, serum osmolality, and the patient's response to therapy. The serum sodium level should not decrease by more than 8 to 15 MEQs per liter in an 8-hour period. Quickly reducing levels can cause a rapid shift of water back into the cells, causing cerebral edema and neurologic complications. This risk is greatest in the patient who developed hypernatremia over several days or longer. Hyponatremia. Hyponatremia, low serum sodium, may result from a loss of sodium-containing fluids, water excess in relation to the amount of sodium, dilutional hyponatremia, or a combination of both, Table 16.4. Hyponatremia is usually associated with ECF hypoosmolality from the excess water. To restore balance, fluid shifts out of the ECF and into the cells, leading to cellular edema. Common causes of hyponatremia from loss of sodium-rich body fluids include draining wounds, diarrhea, vomiting, and primary adrenal insufficiency. Inappropriate use of sodium-free or hypotonic IV fluids causes hyponatremia from water excess. This may occur in patients after surgery or major trauma, or if we give fluids to patients with renal failure. Patients with psychiatric disorders may have an excess water intake. Syndrome of inappropriate antidiuretic hormone secretion, SIADH, results in dilutional hyponatremia caused by abnormal retention of water. See Chapter 49. Clinical manifestations. The manifestations are due to cellular swelling and first appear in the central nervous system, CNS. Mild hyponatremia has minor, nonspecific neurologic symptoms, including headache, irritability, and difficulty concentrating. More severe hyponatremia can cause confusion, vomiting, seizures, and even coma. If hyponatremia is severe and develops rapidly, irreversible neurologic damage or death from brain herniation can occur. Nursing and interprofessional management, hyponatremia. Nursing diagnoses. Nursing diagnoses and collaborative problems for the patient with hyponatremia include electrolyte imbalance, risk for injury, acute confusion, potential complications, seizures, and coma. Nursing implementation. Managing hyponatremia from fluid loss includes replacing fluid using isotonic sodium-containing solutions, encouraging oral intake, and withholding all diuretics. In mild hyponatremia caused by water excess, fluid restriction may be the only treatment. Loop diuretics and demeclosaline may be given. If hyponatremia is acute or more serious, small amounts of IV hypertonic saline solution, 3% sodium chloride, can restore the serum sodium level while the body is returning to a normal water balance. Vasopressor receptor antagonists, drugs that block the activity of ADH, are used to treat patients who cannot tolerate fluid restrictions or have more severe symptoms. These drugs include conivaptan, Vaporsol, and tolvaptan, Samska. Conivaptan is given IV to hospitalized patients with severe hyponatremia from water excess. Tolvaptan is given orally to treat hyponatremia from heart failure or SIADH. Monitor serum sodium levels and the patient's response to therapy. Avoid rapid correction or overcorrection. The level should not increase by more than 6 to 12 millicues per liter per hour in the first 24 hours and 18 millicues per liter or less per hour within 48 hours. Quickly increasing sodium levels can cause osmotic demyelination syndrome with permanent damage to nerve cells in the brain. An accurate urine output record is essential. The patient may need a urinary catheter placed if unable to help with monitoring output. If the patient has an altered sensorium or is having seizures, initiate seizure precautions. Potassium imbalances. Potassium is a major ICF cation, with 98% of the body potassium being in cells. For example, potassium concentration within muscle cells is around 140 millicues per liter. Potassium concentration in ECF is 3.5 to 5.0 millicues per liter. Sodium-potassium pump in cell membranes maintains this concentration difference by pumping potassium into the cell and sodium out. Insulin helps by stimulating the sodium-potassium pump. Because the ratio of ECF potassium to ICF potassium is the major factor in the resting membrane potential of nerve and muscle cells, potassium imbalances often affect neuromuscular and cardiac function. Potassium is involved with regulating intracellular osmolality and promoting cellular growth. It is required for glycogen to be deposited in muscle and liver cells. It also plays a role in acid-base balance, discussed in the section on acid-base regulation later in this chapter. Diet is the main source for potassium. The typical Western diet contains roughly 50 to 100 millicues of potassium daily, mainly from protein-rich foods and various fruits and vegetables. Many salt substitutes used in low-sodium diets have substantial potassium. Patients may receive potassium from parenteral sources, including IV fluids, transfusions of stored hemolyzed blood, and certain medications, e.g. potassium penicillin. The kidneys are the primary route for potassium loss, eliminating about 90% of the daily potassium intake. Potassium excretion depends on the serum potassium levels, urine output, and renal function. When serum potassium is high, urine potassium excretion increases, and when serum levels are low, excretion decreases. Large urine output can cause excess potassium loss. Impaired kidney function can cause potassium retention. There is an inverse relationship between sodium and potassium reabsorption in the kidneys. Factors that cause sodium retention, e.g. low blood volume, hyponatremia, aldosterone secretion, cause potassium excretion. Hyperkalemia. Hyperkalemia, high serum potassium, may result from impaired renal excretion, a shift of potassium from ICF to ECF. A massive intake of potassium, or a combination of these factors, table 16.5. The most common cause of hyperkalemia is renal failure. Adrenal insufficiency with subsequent aldosterone deficiency leads to potassium retention. Factors that cause potassium to move from ICF to ECF include acidosis, massive cell destruction, as in burn or crush injury, tumor lysis, severe infections, and intense exercise. In metabolic acidosis, potassium ions shift from ICF to ECF in exchange for hydrogen ions moving into the cell. Digoxin-like drugs and beta-adrenergic blockers, e.g. propanolol, can impair entry of potassium into cells, resulting in higher ECF potassium concentrations. Several drugs, such as NSAIDs, potassium-sparing diuretics, angiotensin II receptor blockers, e.g. losartan, and angiotensin-converting enzyme ACE inhibitors, e.g. lisinopril, can contribute to hyperkalemia by reducing the kidney's ability to excrete potassium. Clinical manifestations. The increased potassium concentration outside the cell changes the normal ECF and ICF ratio. This results in increased cell excitability and changes in impulse transmission to the nerves and muscles. The most clinically significant problems are the changes in cardiac conduction. The initial finding is tall, peaked T waves. As potassium increases, cardiac depolarization decreases, leading to loss of P waves, a prolonged PR interval, ST segment depression, and widening QRS complex. Figure 16.14. Heart block, ventricular fibrillation, or a cardiac standstill may occur. The patient may have fatigue, confusion, tetany, muscle cramps, paresthesis, and weakness. As potassium increases, loss of muscle tone and weakness or paralysis of other skeletal muscles, including the respiratory muscles, can occur, leading to respiratory arrest. Abdominal cramping, vomiting, and diarrhea occur from hyperactivity of GI smooth muscles. Nursing and interprofessional management hyperkalemia. Nursing diagnoses. Nursing diagnoses and collaborative problems for the patient with hyperkalemia include electrolyte imbalance, activity intolerance, impaired cardiac output, potential complication, dysrhythmias. Nursing implementation. Management of hyperkalemia consists of the following. 1. Stop oral and parenteral potassium intake, table 16.6. 2. Increase potassium excretion. This may be done with loop or thiazide diuretics, dialysis, Pataromer, Valtessa, and or sodium polystyrene sulfonate, Kxalate. Kxalate, given orally or rectally, is used acutely to bind potassium in the bowel. Each gram of the drug removes roughly 1 millicu of potassium. Patients with renal failure need hemodialysis. Pataromer, given orally, also binds potassium in the GI tract. It takes several hours to days to work and is best for patients with chronic hyperkalemia. Pataromer binds with many other oral drugs and reduces their effectiveness. You should not give it within 6 hours of other drugs. Force potassium from ECF to ICF. A combination of IV regular insulin with dextrose and beta-adrenergic agonist stimulates the sodium-potassium pump, shifting potassium into cells. Using these drugs together is more effective than using either alone. Both metered dose inhalers and nebulized beta-adrenergic agonists, e.g. nebulized albuterol, are equally effective. IV sodium bicarbonate is an option if the patient is acidotic. 4. Stabilized cardiac membranes. IV calcium chloride, or calcium gluconate, does not lower the potassium, but serves as an antagonist to reverse the toxic effects on the cardiac cell membrane. This protects the patient from life-threatening dysrhythmias. When the potassium elevation is mild and the kidneys are functioning, it may be enough to 1. Withhold potassium from the diet and IV sources, and 2. Increase renal potassium excretion by giving fluids and loop or thiazide diuretics. Patients with severe hyperkalemia or symptomatic patients should receive treatment to force potassium into cells. Use continuous ECG monitoring for all patients with clinically significant hyperkalemia to detect dysrhythmias and monitor the effects of therapy. The patient with dangerous dysrhythmias should receive IV calcium immediately. Monitor BP because giving calcium rapidly can cause hypotension. When giving insulin, monitor for hypoglycemia and give glucose as needed. Monitor serum potassium levels as appropriate. Hypokalemia. Hypokalemia, low serum potassium, can result from an increased loss of potassium, an increased shift of potassium from ECF to ICF, or, rarely, from deficient dietary potassium intake. The most common causes are abnormal losses from either the kidneys or GI tract. GI tract losses are associated with diarrhea, laxative misuse, vomiting, and ileostomy drainage. Renal losses occur when a patient is diuresing or has a low magnesium level. Low magnesium levels stimulate renin and aldosterone release, resulting in potassium excretion. Among the factors causing potassium to move from ECF to ICF are insulin therapy, especially in conjunction with diabetic ketoacidosis, and beta-adrenergic stimulation, catecholamine release in stress, coronary ischemia. Alkalosis can cause a shift of potassium into cells in exchange for hydrogen, lowering potassium in ECF and causing symptomatic hypokalemia. Clinical manifestations. Hypokalemia alters the resting membrane potential, resulting in hyperpolarization, an increased negative charge within the cell, and impaired muscle contraction. Therefore, the manifestations of hypokalemia involve changes in cardiac and muscle function, Table 16.5. The most serious clinical problems are cardiac changes, including impaired repolarization, resulting in a flattened T wave, depressed ST segment, and the presence of a U wave. The P wave's peak and the QRS complex is prolonged, Figure 16.4. There is an increased incidence of heart block and potentially lethal ventricular dysrhythmias. As with hyperkalemia, skeletal muscle weakness and paresthesias may occur. Severe hypokalemia can cause paralysis. This usually involves the extremities, but can involve the respiratory muscles, leading to shallow respirations and respiratory arrest. Changes in smooth muscle function may lead to decreased GI motility, e.g., constipation, paralytic ileus. Finally, hypokalemia impairs insulin secretion, leading to glucose intolerance and hyperglycemia. Nursing and interprofessional management, hypokalemia. Nursing diagnoses. Nursing diagnoses and collaborative problems for the patient with hypokalemia include electrolyte imbalance, activity intolerance, impaired cardiac output, potential complication dysrhythmias. Nursing implementation. Managing hypokalemia consists of oral or IV potassium chloride, KCl, supplements, and increased dietary intake of potassium. Consuming potassium-rich foods can usually correct mild hypokalemia. See Table 16.6 for foods that are high in potassium. Clinically significant hypokalemia requires giving oral or IV KCl. IV KCl infusion rates should not exceed 10 millicues per hour unless the patient is in a critical care setting with continuous ECG monitoring and central line access for administration. IV KCl must be given by infusion pump to ensure correct administration rate. Because KCl is irritating to the vein, assess IV sites at least hourly for phlebitis and infiltration. Infiltration can cause necrosis and sloughing of the surrounding tissue. Patients who are critically ill and those at risk for hypokalemia should have continuous ECG monitoring to detect cardiac changes. Monitor serum potassium levels and urine output as appropriate. KCl is usually given only if the urine output is at least 0.5 milliliters per kilogram of body weight per hour. Because patients on digoxin therapy have an increased risk for toxicity if their serum potassium level is low, monitor the patient for digitalis toxicity. Patients who have confusion, lethargy, or GI problems, including nausea, vomiting, or poor appetite, may have digitalis toxicity. Visual problems, including blurred vision and changes in color vision, may be seen in digitalis toxicity. Teach patients ways to prevent hypokalemia. Table 16.7. Patients at risk should have regular monitoring of serum potassium levels. Teach the patient taking digitalis to report signs and symptoms of digoxin toxicity at once to the HCP. Calcium imbalances. Calcium has a role in many metabolic processes. It is the major cation in bones and teeth. Calcium plays a role in blood clotting, transmission of nerve impulses, myocardial contractions, and muscle contractions. The major source for calcium is dietary intake. Calcium absorption requires the active form of vitamin D. Vitamin D is obtained from foods or made in the skin by action of sunlight on cholesterol. The total body content of calcium is about 1,200 grams. Bones contain 99% of the body's calcium. The rest is in plasma and body cells. Of the calcium in plasma, 50% is bound to plasma proteins, primarily albumin. 40% is in a free or ionized form, and the rest is found bound with phosphate, citrate, or carbonate. The ionized or free calcium is biologically active. The serum pH influences how much calcium is ionized or bound to albumin. A decreased plasma pH, acidosis, decreases calcium binding to albumin, leading to more ionized calcium. An increased plasma pH, alkalosis, increases calcium binding, leading to decreased ionized calcium. Serum calcium levels reflect the total level of all forms of plasma calcium. Serum albumin levels affect the interpretation of total calcium levels. Total calcium values increase or decrease directly with serum albumin levels. Ionized calcium levels are measured using special laboratory techniques or calculated using a formula. Albumin levels do not affect ionized calcium levels. Parathyroid hormone, PTH, and calcitonin regulate calcium levels. Since the bones serve as a readily available store of calcium, the body can usually keep calcium levels normal by regulating the movement of calcium into or out of the bone. Low serum calcium levels stimulate the parathyroid glands to make and release PTH. PTH increases bone resorption, movement of calcium out of bones, increases GI absorption of calcium, and increases renal tubule reabsorption of calcium. High serum calcium levels stimulate the release of calcitonin from the thyroid gland. Calcitonin has the opposite effect of PTH. It lowers the serum calcium levels by increasing calcium deposition into bone, increasing renal calcium excretion, and decreasing GI absorption. Hyperkalemia. Hyperkalemia, high serum calcium, is caused by hyperparathyroidism in about 2/3 of persons. Cancers, especially hematologic, breast and lung cancers, cause the remaining third. Cancers lead to hyperkalemia through tumor-producing factors that prompt osteoclastic activity and bone resorption. More rare cases include thiazide diuretic use, prolonged immobilization, and increased calcium intake, e.g., use of calcium-containing antacids. Excess calcium acts like a sedative, leading to reduced excitability of muscles and nerves. Neurologic manifestations begin with fatigue, lethargy, weakness, and confusion, and progress to hallucinations, seizures, and coma. Changes in cardiac conduction can lead to dysrhythmias, including heart block and ventricular tachycardia. Table 16.8 lists the causes and manifestations of hyperkalemia. Nursing and interprofessional management, hyperkalemia. Nursing diagnoses. Nursing diagnoses and collaborative problems for the patient with hyperkalemia include electrolyte imbalance, acute confusion, impaired physical mobility, potential complication, dysrhythmias. Nursing implementation. Management depends on the degree of hyperkalemia, patient's condition, and underlying cause. Patients with mild hypercalcemia should stop any medications related to hypercalcemia, start a diet low in calcium, increase weight-bearing activity, and maintain adequate hydration. The patient must drink 3,000 to 4,000 milliliters of fluid daily to promote the renal excretion of calcium and decrease the chance of kidney stone formation. Fluids that promote urine acidity, cranberry or prune juice, will help to prevent formation of stones. Managing severe hypercalcemia includes giving IV isotonic saline, a biphosphonate, and calcitonin. IV saline therapy requires careful monitoring. Fluid overload can occur in patients who cannot excrete the excess sodium because of impaired renal function. Biphosphonates, e.g. pamidronate, zoledronic acid, are the gold standard in treating hypercalcemia, particularly when caused by cancer. They interfere with the activity of osteoclasts, cells that break down bone. Because it takes 2 to 4 days for them to achieve maximum effect, patients receive calcitonin injections for an immediate effect. Calcitonin rapidly increases renal calcium excretion. However, therapy is effective for only a few days and may cause tachycardia. For patients who do not respond to biphosphonates or have renal impairment, denosumab, Prolia, may be used as an alternative treatment. Dialysis is an option in life-threatening situations.